Let's jump right into today's explainer. We're going to be unpacking a really fascinating learning framework known as the Vibrown's Clinical Cognition OS Companion. Specifically, we're zooming in on its case question module router. So if you're a focused learner looking into how structured digital frameworks can actually map out complex clinical reasoning, well, you're in exactly the right place.
Okay, let's dive into this. We'll start by introducing Vibrowns. Then look at step 1, the clinical case. From there, we'll explore 3 distinct viewpoints: the patient perspective, the clinician perspective, and the researcher perspective, before finally wrapping up with generating the module map.
Part 1. Introducing Vibrowns, a framework for clinical cognition. Now, before we go any further, we absolutely have to establish a critical narrative boundary here. Vibrowns is a learning aid only. It is not a clinical tool. Basically, every module referenced in Vibrowns is a prompt-based reasoning exercise. So the outputs you get, those are strictly learning observations, not clinical decisions. They absolutely require independent clinician verification. And, of course, it's essential that this system is only ever used with fully de-identified consented case material. Let's look at how this builds a logical pathway. The router operates on a really clean, simple 3-step workflow. Step 1 is simply inputting the case under review. Step 2 asks, whose questions? Meaning, hey, what perspective are we looking from right now? And step 3 generates the final questions and the module map. It's just a super elegant pipeline, guiding you from raw data to structured inquiry.
Section 2, Step 1, the clinical case. Anchoring the analysis.
So, the crucial point is that every analysis needs a concrete anchor. For our walkthrough, we have a dummy case, a 62-year-old female presenting with 3 days of worsening shortness of breath, or dyspnea, along with bilateral leg swelling. Her history includes hypertension. Vitals show oxygen saturation at 91% on room air. The exam reveals a raised jugular venous pressure, bibasal crackles in the lungs, and pitting edema. Keeping this specific clinical picture in mind is absolutely key, because it's going to contextualize every single feature we talk about next. Part 3, the patient perspective. Focus on clarity. Once that dummy case is locked in, the router asks its step 2 question: whose questions are we generating? If we select the patient or advocate perspective, the entire framework pivots. Instead of throwing out complex medical jargon, the focus shifts to 3 immediate areas for a 62-year-old patient. First, plain language explanations. How do we explain what's happening to her clearly? Second, monitoring needs. What exactly does she need to watch out for at home? And third, decisions. What immediate choices do the patient or her advocate need to navigate right now? It structures the learning entirely around empowerment and clarity.
Section 4, the clinician perspective, diagnostics and safety.
Now, when we look at the exact same case through the clinician viewpoint, the router recalibrates to focus on the heavy lifting of medical reasoning. It zeroes in on building a differential diagnosis for those specific symptoms of dyspnea and leg swelling. But it doesn't stop there. It deliberately prompts an analysis of cognitive bias, literally challenging the learner to think about what assumptions they might be making. It also highlights patient safety protocols and structures the necessary clinical workup. And this brilliantly illustrates the true value of this learning aid. On one side, the patient focus is anchored in the immediate, practical realities of understanding and living with a condition. On the other side, the clinician focus is deeply analytical, diagnostic, and systems-oriented. It's the exact same clinical data, but the cognitive map generated to understand it changes entirely based on the user's role. Part 5, the researcher perspective, evidence and appraisal. A researcher isn't managing the immediate bedside care, nor are they the one experiencing the illness. When we run our patient's case through the researcher perspective, priorities shift entirely toward the literature. The router generates learning observations centered around formulating structured questions, appraising the existing evidence, handling the clinical write-up, and analyzing long-term prognosis data. To pull this off, the researcher relies heavily on PICO. For a quick refresher, PICO stands for population, intervention, comparison, and outcome. It's a highly structured framework used by researchers to formulate precise, answerable clinical questions. So, under this perspective, the router trains the learner to convert raw case details, like hypertension and bibasal crackles, into a rigorous academic inquiry. This rule of 3 right here is where the magic of shifting perspectives really happens. The Vibrowns router processes the exact same case of dyspnea and edema in 3 distinctly different ways, entirely depending on who is asking the questions. The patient needs plain language and monitoring. The clinician needs differentials and safety checks, and the researcher, they need PICO and evidence appraisal. It's one case, but three completely different cognitive pathways to explore it.
Section 6, generating the module map, the final output.
Now, what's really interesting about this slide is the map itself. Once the case is locked in and a perspective is chosen, we hit step 3 of the pipeline. The generated module map isn't some black box AI mystery. It's strictly defined as a fixed offline mapping layer. It's actually built directly on top of a public module directory created by Dr. Avinash Kumar Gupta back in June 2026. This library and framework are available under a Creative Commons BY 4.0 license, which means the fundamental architecture is open, structured, and entirely transparent. We also need to talk about technical boundaries, because these are absolutely crucial for data safety and educational integrity. First, as we just mentioned, it's a fixed offline mapping layer. Most importantly, it does not call any external AI. Let me say that again for sure clarity. It does not send your data out to an external AI processor. It also doesn't modify or explicitly endorse the source material it maps to. Instead, it simply links out to the full directory, functioning purely as a prompt-based reasoning exercise to actively guide your own clinical deductions.
Well, that brings us to the end of our explainer, leaving us with a pretty compelling thought. How might prompt-based reasoning exercises and this kind of multi-perspective mapping shift your own approach to clinical learning? Whether you're studying to be a clinician, reviewing cases as a researcher, or advocating as a patient, structured cognition is a profoundly powerful tool. Thanks so much for joining me on this walkthrough of the Vibrounce Case Question Module Router. Keep learning, keep asking questions from every possible angle, and I'll see you in the next explainer.